Hello everyone, this is Group H and today we will be going through a model of carcinoma of endometrium. So let us see. So carcinoma of endometrium refers to the malignant epithelial tumors arising from the lining of the uterus, typically affecting the postmenopausal woman. It is the most common invasive cancer of the female genital tract in developed countries. In this histopathological model, here we can see there is the excessive growth of tumor mass which is seen on the endometrial lining, and it has been metastasized to the part of the fallopian tube. The tumor may appear as a polypoid nodular or diffuse thickening of the endometrium. Polypoid masses of the uterine cavity are common, but sometimes they present as fungating or friable mass. The color and the texture is usually grey-white to yellowish, soft and friable. The areas of necrosis may also be present in the regions. Moving towards the microscopy, so here the endometrial glands resembles like normal, but there is architectural complexity. There are back-to-back glands with reduced or no intervening stroma. Here there is nuclear atypia, that is enlarged pleomorphic nuclei are seen with prominent nucleoli. The mitotic figures have been increased, and this may also show squamous differentiation or mucinous areas in between. The invasion into myometrium may also be seen. The etiology of endometrial carcinoma involves a combination of genetic, hormonal, and environmental factors. Prolonged unopposed estrogen exposure due to obesity, polycystic ovarian syndrome, estrogen therapy, or estrogen secreting tumors is a major risk factor. Nulliparity, late menopause, diabetes, and hypertension also contribute in this. There are two types of endometrial carcinoma, that is type 1, which is endometrioid type, and type 2, that is non-endometrioid type, including the serous and clear cell types. The type 1 accounts for nearly 80% of the cases and is estrogen dependent, often preceded by endometrial hyperplasia. It usually occurs in perimenopausal women and has a relatively favorable prognosis. Type 2 is estrogen independent, more aggressive, arises in atrophic endometrium and occurs in older women. The pathogenesis of type 1 involves mutation in PTEN, PIK3CA and mismatch repair genes like MLH1, while type 2 frequently involves P53 mutations. Microsatellite instability is a common feature in type 1 tumors, particularly in patients with Lynch syndrome. Type 1 tumors show glandular patterns similar to normal endometrial tissue, while type 2 tumors show papillary or solid architecture with high-grade cytology. The lab diagnosis includes transvaginal ultrasound followed by endometrial biopsy or dilation and curettage of histological confirmation. The elevated CA125 may be used for monitoring but is not specific. The imaging techniques like CT or MRI helps in staging. The treatment of choice depends on the stage but generally includes total abdominal hysterectomy with bilateral salpingo-oophorectomy. For early stage type 1 tumors, this is often sufficient, but high risk or advanced stage disease may require adjuvant radiotherapy and chemotherapy. Progestins, example medroxyprogesterone acetate, may be used in hormone responsive tumors, especially in young patients desiring fertility preservations. For advanced or recurrent cases, carboplatin and paclitaxel is the chemotherapy regimen of choice. This was all about our model, that is CA of endometrium. Thank you so much.